Good evening to everyone. Today is very special day for us as very eminent doctor, Dr. Naveen Rajgopalan is going to deliver a lecture on essentials of right heart catheterization. Not only in the management of this heart failure, I heard his lecture before, which he covered almost all the features in the right heart catheterization. So I request Dr. Usha to take over and the team Dr. Rupali and Dr. Hema to start the program. And I request now Dr. Hema to introduce Dr. Naveen Rajgopalan.
Yeah. Hello, everyone, and great to have you, sir, here with us. So, actually, Dr. Rajgopalan received his Bachelor's of Science in Chemistry and Medical degree from the Ohio State University. He completed internal medicine registry training um, at Mayo Clinic in Rochester, Minnesota, before pursuing a cardiovascular fellowship at the University of Pittsburgh. He obtained an additional degree of training at the University of Pittsburgh in advanced heart failure and cardiac transplantation. He is board certified by the American Board of Internal Medicine in cardiovascular medicine and advanced heart failure and transplant cardiology. So from 2009 to 2018, he was the director of heart failure and medical director of heart transplantation at the University of Kentucky. And in 2019, he relocated to New Jersey, where he was appointed as the medical director of heart failure and transplant cardiology at Newark Beth Israel Medical Center. He was recruited back to the University of Kentucky in 2020 to serve as the director of the Gill Heart and Vascular Affiliate Network. He is a member of the American College of Cardiology, Heart Failure, and Transplant Leadership Council. So great to have you in the program with us. Thank you very much for being with us today.
Thank you. Thank you for the kind introduction, and thank you, everybody, for being here. So I'm speaking about the essentials of right heart catheterization in the management of heart failure. So right heart catheterization is an integral part of how we manage heart failure patients, but there's sometimes some confusion about what its exact role is. So hopefully this lecture will help give some basic guidance as to how to perform the procedure, as well as how we use the data in the management of patients. So just some nomenclature. So what is right heart catheterization? There's different terms for this. It's also known as Swan-Ganz catheterization. This is from the name of two physicians, Dr. Swan and Dr. Ganz, who revolutionized the technique many decades ago. It is basically a catheter that is floated into the pulmonary artery. So it's also called a PA catheter. So all these terms are used interchangeably. In the cath lab, we'll often say right heart catheterization. When you work in the ICU, they'll say we need to place a PA catheter or we need to place a Swan. These all mean the same thing. Just so you're aware, this is different than a left heart catheterization. In a left heart catheterization, we're going to the left side of the heart. So that's usually an arterial access, and that's usually how we get a pulmonary, a coronary angiogram. So that's when you look for blockages to see if your patient needs a stent. So sometimes patients will get confused. They'll say, I've already had a heart cath. And I say, well, that was a left heart catheterization that you had. We're talking about a right heart catheterization. So as I mentioned, it is a venous access procedure. The most common location where we access is the right internal jugular vein, but some operators use the brachial vein in the arm. The nice thing about using upper access from above the heart is that if you go from especially if you go from the internal jugular vein, the catheter naturally will oftentimes go from the right atrium to the right ventricle to the pulmonary artery, and then you can also go to the pulmonary capillary wedge position. So if you're in the ICU, you can do this at the bedside. If you go from the femoral vein, from the leg, or from the left IJ, it's more tortuous, and sometimes you will need fluoroscopy. So that's basically a special camera to guide, to manipulate the catheter to go where you want it to go. Sometimes even from the right IJ, you're not successful, so you may need fluoroscopy. But many times you don't need it. You can tell based on the waveform where you're at. So the goal is basically to go from the right atrium to the pulmonary artery. Here's a picture of how a catheter looks. There's different types and different forms. At least in the United States, they're almost always yellow. So when I walk into an ICU room and I don't know the patient, I often can tell right away that they have this catheter because you'll see it in the neck and you'll see this yellow apparatus, and you can immediately tell what it is. So it's usually placed through another access catheter that's usually in the neck. And so it has multiple ports, which I'll talk a little bit about later. But its length is 110 centimeters. Obviously, you need it long enough that it's able to reach the pulmonary artery and then able to wedge the catheter, which I'll explain a little bit later. For most people of regular size, even big patients, this is plenty long. I can't even say, not even sure if they make bigger sizes, to be honest. But for almost all, even for large people, greater than 6 foot, it's long enough. So why do we refer patients for right heart catheterization? Why do we need hemodynamics? And so there's many different reasons that a patient may undergo right heart catheterization. One of them is to diagnose pulmonary hypertension, which I won't spend a lot of time talking about. That's basically a disease that can be associated with heart failure, but it can be a disease that's completely separate from heart failure, which is pulmonary arterial hypertension, where patients have a normal left ventricle, they have a normal left-sided system, but they just have intrinsic pulmonary artery hypertension, which then leads to right ventricular dysfunction. If patients show up in the ICU and they're hypotensive and in shock, right heart catheterization can guide in the management of these patients, can also differentiate between different types of shock. If patients have uncertain volume status, so if you don't know if they're volume overloaded or you're in a disagreement with a nephrologist, a kidney doctor about, does this patient need diuretics, or are they wet, or are they dry, right heart catheterization can be helpful. And then we use them a lot in chronic heart failure for assessing patients if their heart failure is end stage, if they need to be considered for LVAD or heart transplantation. And then obviously if a patient just says, I'm short of breath, and you don't know what's causing it, obviously you'll do non-invasive tests first, like echocardiogram, maybe even a stress test. But if you're still struggling with what's wrong with the patient, a right heart catheterization can be helpful. On the right is the official guidelines. I just want to focus on, this is from the ACC AHA heart failure guidelines. One of the things I want to focus on is number 3. So in patients with heart failure, routine use of invasive hemodynamic monitoring or placement of a PA catheter is not recommended. Okay, so if a patient I see, there's no such thing as a patient has not had a right heart cath in a while, let's get hemodynamic information. That's never standard of care. There's no reason to get a right heart cath if a patient is stable, if they're doing well, and unless you are trying to answer a specific question as I outlined on the left-hand side. So I'm a heart failure cardiologist, so I see patients all the time in my clinic with heart failure. And as I just told you, it's not indicated just to do a right heart cath, just to get hemodynamic information. So in this review paper, which I was privileged to write, that was just published in JACC Heart Failure, we brought up clinical criteria that suggests the need, that a patient with heart failure is getting worse, maybe has onset of low cardiac output or the beginnings of cardiogenic shock, which again, I'll talk about a little bit later. And so these are just some features, when I see a patient in clinic, that this patient may need to be considered for a hemodynamic assessment to determine if they're getting worse and if we need to consider other options, such as consideration of heart transplantation. So the most common ones that we see in clinical practice would be, especially in a young patient, would be worsening fatigue, the onset of hypotension, and then the fourth one, down titration of medical therapy. So if you have a patient that's been on medical therapy but is now getting worse and now having hypotension and they cannot tolerate medical therapy, that is somebody that may be on the downward trajectory and may need to be considered for options like heart transplantation. So in a patient, and this framework that I have here is useful in not just the ICU, but also in on the outpatient side. Because when I do a right heart cath on one of my patients that with chronic heart failure or acute heart failure, I like to see what box are they in based on their cardiac output, which is a fact which is corrected for their body surface area to have cardiac index, and their pulmonary capillary wedge pressure to put them in one of these four boxes. The most concerning criteria to identify is those patients that are cold and wet, those patients that have low cardiac index as well as high wedge pressure, volume overload. And if some of these terms seem a little bit confusing, I'll be talking about them in the lecture in the next several slides. So the nice thing about a right heart catheterization is that there's very few contraindications. The biggest one is infection. So obviously we're getting IV access, we're putting a catheter. If a patient is bacteremic, has bacteria in their bloodstream, we don't want to introduce a foreign body. So active infection, bacteremia is probably the biggest contraindication. Obviously, this catheter is going into the right ventricle. So if there is a lesion on the right ventricle and we're worried it may embolize, that would be like a endocarditis or a tumor, we may have some concerns. Now, I'll be honest, you can still do a right heart cath. The catheter is very soft. It's probably, in most cases, not going to dislodge anything, but you just need to be aware of, and you may want to weigh the risks and benefits. If a patient has a left bundle branch block, this catheter, if it hits, if the patient is unlucky and it can induce, not common, it's rare, but it can induce a right bundle branch block. So then if you have a pre-existing left bundle branch block, you can cause complete heart block. I say it's rare, but actually one of my patients, when one of my colleagues was doing his cath, actually had this happen. He developed transient complete heart block, and which eventually resolved, but he had to go to the ICU for several hours. I want to bring up severe coagulopathy. Again, this is a venous stick, so bleeding is not usually common. We're not going in the artery, so in most cases, you can do this procedure safely, even if your patient is on anticoagulation. Obviously, if they're having active bleeding or they're severely coagulopathic, you may not want to do the procedure. But we routinely do patients while on anticoagulation, such as warfarin. So now I'm going to talk about the basics of how we get the data. So obviously, patient, if the data is not correctly obtained, it's not useful. So the patient has to be on the cath. Again, I'm going to talk about the cath lab table, but as I said earlier, these can be done at the bedside in the ICU. But obviously, then it's even more important in the ICU to make sure everything is level for when you are recording information. So you need to have the patient laying flat, supine. The transducer, which is the pressure transducer, which is actually measuring the pressure, has to be leveled, right? So if the transducer is too low or too high, every variable that you obtain is going to have an error, either too high or too low. So it has to be leveled it's leveled at the level of the left atrium, which is the mid chest, right? So you or a nurse has to look at the patient laying flat, see where the mid chest is, and use a ruler also to help guide you, because that can be a little more difficult if your patient is big, and put the transducer at the mid chest level, and that is fairly standard. And then we put in a catheter, and then we have to zero, so we zero to atmospheric pressure, and then the biggest concern if we're getting access to the neck is avoiding the carotid artery. We want to avoid the carotid artery because that could increase the risk of a stroke. So we often will use an ultrasound probe to make sure we can visualize the internal jugular vein as well as the carotid artery and stay away from the carotid. So to get accurate data, so when you're starting the case, you need to know the patient, right? So sometimes I'll do procedures on patients whom I don't know, they're not my patient. And so before, when I consent the patient and before I start, I know why I'm doing the procedure. What is the person who's ordering this test, what did they want to find out? And so again, that's something you should know with every patient that's getting any procedure. What is the goal of the procedure? Because sometimes the data you may get may not be what you're expecting. And so that could still be accurate, but then that may lead you to troubleshoot. You say, I'm getting data that doesn't make sense based on what I know about the patient, and that may spur you to look at if there's anything going wrong. Do not obtain pressures while the patient is talking. That if I do these cases when the patient talks or has a cough, the pressures go kind of haywire. They go up and down. So I've seen trainees actually record data while the patient's talking. I say, look, the patient has to stop talking. I will tell patients often that if something is bothering you, you can speak, but try not to talk, because if you talk, it's going to make us be here longer. And most patients don't want to be on the cath lab table any longer than they have to. It's a little uncomfortable. So they'll often not say anything. But I do tell them, if something's really bothering you, if you're worried about something, feel free to speak. But if they're speaking, you cannot get any measurements. PVCs affect the measurements. Now, sometimes you can't do anything about it. The patient's just having PVCs or PACs, but sometimes it is related to the catheter. And so then you just need to find a position where it's less of a problem. Or when it stops, I tell the cath lab staff, record the pressure. They'll have recorded the pressure, but the patient was having PVCs. And I say, look, delete that. And then we'll just wait there until the pressures, kind of settle, until there's no PVCs. And then I say, now record the pressures. Because the computer will record what you tell it to record, and what the computer records may not be accurate. So that's, again, don't just, you can't just rely on the computer to record all the data because the computer is not smart. It doesn't know what's going on with the patient. So these are some normal hemodynamics. So normal right atrial pressure is, typically less than 5 millimeters of mercury. Pressure, and these are, when I say normal, these are pressures for, like healthy people, right? So patients may have slightly abnormal pressures, but they're still pretty good given their particular condition. But these values here are normal for for a human that does not have any disease. So right ventricle, usually the systolic pressure is 20 to 30. Same with the pulmonary artery. The mean is less than 20. So any mean pulmonary artery pressure greater than 20 milliliters of mercury is considered pulmonary hypertension of some category, which I'll talk about later, and is abnormal. And wedge pressure, again, is usually between 4 and 14. Just anything less than 15 is considered normal. You or I, if we've just had, if we haven't eaten all day, and, if we had a right heart cath right now, if you had coffee in the morning, we'll probably have something closer to like 4 or 5. But anything less than 15 can be considered normal. One of the things that I ask about is that if you have a catheter in a patient and they're breathing normally, you will see some fluctuation in the pressures. It's usually mild, right? In terms of clinical significance, the difference in the pressures is usually minimal, like a couple of millimeters of mercury. But by convention, we try to measure pressures at end expiration. But we don't tell the patient to take a breath and hold the breath. So we just try to observe them while they're breathing and record. And again, when you record, at least in my lab, when the computer records, they'll record for a certain number of beats. But we try to look at what is the value at end expiration. And if you don't remember, if you're looking at the tracing of a patient, the end expiration is the maximum value. So there'll be this undulation, and whatever is the top will be where the patient was at end expiration. But we try to avoid breath hold. We try to avoid sedation. Now, if you gave a patient light sedation, but they're breathing normally, it's probably going to be okay, but you have no idea how the patient will react to sedation. So I've given, some of the patients are insistent. They won't be still, and they'll say, I need something. And you give them something, and then they're snoring. And so then that really interferes, because then they're taking deep breaths. You can try to wake them up. Sometimes I have woken them up and then they breathe normally, or I just let the sedation fade away. But, this is like the book answer. Don't give sedation. But in clinical practice, it can be difficult depending on the expectations of the patient. Because sometimes patients will just say they won't, when I consent them, they'll say that they really want something. And if you have to give something, it's maybe better to give them an oral medication before the procedure to kind of take the anxiety away, as opposed to giving them an IV medicine in the cath lab, because then they may fall asleep, and that could lead to error. Now, even without sedation, if your patient has severe lung disease or they're obese, you will often see prominent respiratory variation. I note this on the report, but to be honest, we don't know what this means, right? So you'll see a patient where the variation is very pronounced. And is that an adverse prognostic factor? The answer is we don't know, but it is important to record. So maybe years from now, we'll have determined that that is a concerning sign, but currently we don't know what it means. So here's a right atrial waveform, right atrial pressure waveform. And you can see here's the EKG as well. A normal right atrial pressure waveform will have an A wave and a V wave. The A wave is what occurs with atrial contraction, or we call the atrial kick, where the atrium contracts and then blood goes into the ventricle, to the right ventricle. And then there's also a V wave. The V wave is passive filling of the right atrium, which is when blood goes from the SVC or the IVC into the right atrium. So in a normal waveform, you'll see an A wave and a V wave. And so sometimes you will note prominent V waves if the atrium is non-compliant, or if there is tricuspid regurgitation, you'll see prominent V waves, and you should note that on any report. But by convention, usually the mean pressure, when we talk about end, we try to look at pressures at end diastole, particularly with the wedge pressure, which I'll talk about later. We want to average the A wave. So the peak and the trough of the A wave, the midpoint. Now, in clinical practice, if you have a waveform like this, the computer's mean value will correspond very well to what the mean A wave pressure is. Now, but if you have very tall V waves and you have prominent respiratory variation, that's when you need to examine the strip and say, this is what the pressure is, and note that there were tall V waves. But if the pressure is like a waveform like this, the computer average over the entire cycle will be close to the end diastolic pressure. Here's the RV pressure waveform. You don't use RV pressures by themselves very often, but we record them obviously because we're going from what's more important is the pulmonary artery pressure, but we're going from the RA. So we always record the RV pressure. And so this is how I just wanted to focus on how it should look, how the waveform looks. The pulmonary artery pressure has a systolic and diastolic pressure, and you'll also see this dicrotic notch, and I'll show you why this is important in the next slide. So this is where the pulmonic valve closes, so you'll see this little hitch in the pressure trend. So that's very important to see because then you know this waveform is accurate. And so you'll have a mean pressure, you'll have a systolic pressure, a diastolic pressure, and a mean pressure. And again, we want to measure the mean pressure at end expiration. Again, you will see some respiratory variation. So this the tallest pressure will be the end expiration. So here is inspiration, and then this is expiration. So this would be right here. The tallest wave would be at end expiration. And again, usually the respiratory variation is modest, but it can be more pronounced with lung disease or with obesity. So if you don't see that dicrotic notch and you get something that looks like this, which looks like a sine wave, this is what's called over-dampening. And you may see this also in the right atrium. So me, since I do these a lot, I'm very well experienced. I'll sometimes see the right atrial pressure tracing just looks damped, where it's just it's just too smooth. And usually that's because of air in the system. So, this is something very easy. I actually, as a routine, when I flush the catheter multiple times before I put it in the patient. But when I put it in the patient and have it in the right atrium, I flush it again because oftentimes there's still, some air on the tip. And when you put it in, that air interferes with the pressure. So I aspirate all the time and I flush again, and you'll always see the waveform improve. But if you make that mistake where you're just getting pressures and then you get into the pulmonary artery and you see something that looks like this is dampened and you need to flush the catheter. If you flush the catheter towards the patient and you still have a problem, you then need to flush towards the transducer. So because there could be a bubble in the transducer. Again, the techs usually do this before you start a case, but sometimes it's done, but somehow a bubble gets into the system again, and then you need to flush it. Like every procedure in medicine, hurrying through the procedure is never the right answer. The test is worthless unless you get the data you need and it's accurate. So the extra literally takes 30 seconds to flush the catheter towards the patient and towards the transducer. Just the minimal amount of time to improve the numbers goes a long way. There's this other factor where you get the opposite of a smooth tracing, where you get a very erratic tracing, which is called under dampening or ringing. Not going to spend a lot of time talking about this. It relates to some things with oscillation and harmonics, which I'll be honest, I'm not smart enough and I'm not an engineer to tell you all about it. But basically with this, you'll often see these erratic waveforms. Systolic pressure is often overestimated. Diastolic may be underestimated, but the mean pressure is still accurate. Again, this can be hard to fix. It could be related to position. So sometimes we will change the position of the catheter, but sometimes you can fix this by injecting a small amount of blood instead of saline into the catheter. So you aspirate a little bit. So sorry, don't inject blood. You basically aspirate the catheter. So now there's a little bit of blood in the catheter. And so then it may not oscillate as much. So spend a few minutes talking about pulmonary capillary wedge pressure because it's, number one of the most important variables we obtain, but it's also one of the most difficult variables to obtain. So what is pulmonary capillary wedge pressure? It basically says, the tip of the catheter has a balloon. So we often will inflate the balloon to allow its transition easier to get into the pulmonary artery. Once we're in the pulmonary artery, we deflate it to get the pulmonary artery pressure. But then we inflate the balloon to try to wedge the catheter, which is basically where we try to advance the catheter till it occludes a branch of the pulmonary artery. And when we do that, we are getting blood, we are getting the waveform then transmitted to the tip of the catheter is no longer a pulmonary artery waveform. It is a left ventricular, it is a pulmonary venous waveform because blood is going from the pulmonary artery to the pulmonary vein into the left-sided, into the left atrium, into the left ventricle. So we are attempting to estimate left ventricular end diastolic pressure. If you want to get LV-EDP directly, you have to put a catheter into the left ventricle, which then means you need arterial access, which then adds to the risk and complexity of the procedure. So we are trying to estimate LV-EDP by advancing a catheter in the right-sided system into the pulmonary capillary wedge position with the balloon inflated. So basically, you can see here, pulmonary capillary wedge pressure is an equivalent for pulmonary vein pressure, which is an equivalent of left atrial pressure, which is an equivalent of left ventricular end diastolic pressure. So here is an example of a pulmonary capillary wedge pressure tracing. That is this top one in red, and this also shows the right atrial pressure. Just by comparison, you can see the waveforms look the same. The pulmonary capillary wedge pressure compared to the ECG is a little bit delayed. So the A wave of the wedge pressure is a little bit later in the ECG than the A wave in the right atrial pressure. And so with pulmonary capillary wedge pressure, we're trying to estimate left ventricular end diastolic pressure. So therefore, wedge pressure should be measured at end diastole, which again is the midpoint of this A wave. So the mean of the peak and the trough of the A wave. However, in clinical practice, the mean wedge pressure across the entire cycle closely estimates left end diastolic pressure. So don't want to get too technical. If you just average the mean, particularly at end expiration, you will get an accurate surrogate for LV-EDP. So a lot of now, there's actually lots of articles about this and lots of controversy in the literature, in the hemodynamic literature, as to how do you report pulmonary capillary wedge pressure. And actually, I had another slide here which I took out because it's just very technical about. But some people would say that actually forget about end expiration, just measure it across the entire cycle and include the V wave. So when you have mitral regurgitation, you'll have patients with tall V waves, which could then, so then if you just measure the wedge pressure at end diastole versus measuring it across the entire cycle, you'll get different values. So now various people say, forget that, just measure it across the entire cycle and include V waves if they're tall. One thing to remember is that when I do the report, I try to mention this and say that the patient has tall V waves so that the mean wedge pressure is high because of tall V waves. And so, so you could basically measure, you could report everything. You could say, well, if you look at end diastole, this is the pressure. If you look at the entire cycle, this is the pressure. Again, sometimes it's better to say everything, but then the person reading the report, especially if they're not a, cardiologist, may just get confused and say, what are you trying to tell me? So this is why it's important to know what is the goal of the procedure. But just so you should know is that there's controversy about this. That's the long story short. And that when I do a report, I definitely try to mention that the V waves, if prominent, are there, because that could have clinical significance. So as I mentioned earlier, when you wedge a patient, that vessel, that catheter should be occluded in the vessel. But how do we know that? How do we know that the vessel is actually occluded? One way we can tell that is by obtaining a saturation in the wedge position. So mixed venous saturation, blood from the pulmonary artery is usually around 70%. Obviously, if the patient is sick, has low cardiac output, that value may be lower. But if you wedge the patient, if you wedge the catheter, that blood is now oxygenated blood because it's blood that's coming back from the pulmonary vein, which has already gone through the lungs. So if your patient is not hypoxic, right? So if they don't have a low saturation, the blood you get from the wedge position should be the same as what you get from the pulse ox. So if you have a pulse ox on your patient and it's reading 98% and you wedge the catheter and you're like, I think I'm in the wedge position, to confirm that, you should get blood. You should aspirate blood, and that should be close to the systemic saturation. So it should be over 90% if your patient is not hypoxic. So if you don't get that, if you're getting 70%, 80%, you're not in the wedge position, and you should keep trying to reposition the catheter until you get it. And sometimes you may not get it. People say you can always get it, but I've had situations where I couldn't get it. Maybe those people are more talented than me. I don't know. But then you should just report, you could not get a wedge pressure. You shouldn't report data that is not correct. It's better just to say that you weren't able to obtain the value. But again, this is a very safe procedure. Taking extra time if the patient is just laying there to get better data is definitely worth the time. So you should definitely try to move the catheter to try to get a wedge saturation that is over 90%. So again, this is kind of a summary. When reporting the wedge pressure, definitely report prominent V waves because those are never normal. If you see prominent V waves, this patient has some left heart, has some disease, whether mitral regurgitation or just a stiff left atrium. So that is significant for structural heart disease. And again, if there's significant respiratory variation, report the end expiratory value and also the mean value as well. So the other thing, which I talked about earlier, that we really need to get one of the most important variables we get with a right heart cath is the cardiac output. So oftentimes when I do a right heart cath, I know what I'm going to see. I know my patient's volume overloaded. I know the wedge pressure is going to be high. But what I'm really doing this for is to see what is their cardiac output. How much blood is their heart actually pumping per minute? That is number one, that is hard sometimes to measure, but the right heart cath is the best test we have to measure that. Echo can give us a guide, but there's no echo parameter that replaces a right heart cath. So I would never diagnose somebody with having low cardiac output on the basis of an echo. In my opinion, they need an invasive hemodynamic monitor. So measuring cardiac output is one of the most important reasons we get a right heart cath. Now, as I said earlier, we reference that to body surface area to obtain cardiac index. Again, so a cardiac output of 3 liters may be normal in a petite woman, but that is not normal in an average-sized man. A cardiac output in a 6-foot man, a male who's 200 pounds should be over 5 liters a minute. And a 100-pound woman or male, that's probably closer to 3 liters. So you have to reference it to body surface area. So normal cardiac index is typically considered anything, over 2.3, 2.4. And so the exact number sometimes is not really what's important. what we're trying to answer is it normal or is it low? And so you need to be aware of there's two ways we can measure cardiac output, and that's via the Fick equation or via the concept of thermodilution. So here's the Fick equation. And so the Fick equation involves four variables, three of which you can measure in the cath lab. Those are SaO2, which is systemic saturation. So you can get that from a pulse ox, right? So that usually 100%, 98%. Mixed venous oxygen saturation, which you can get from the pulmonary artery position. So when the catheter is in the pulmonary artery, you aspirate blood and get a sample of mixed venous oxygen saturation. Hemoglobin, usually most machines in our cath lab will also get a hemoglobin, but if you can't get one, you can also just get a blood sample on your patient and tell the lab to get a hemoglobin. But the other variable is VO2. This is oxygen consumption. In the cath lab in the United States, this is very difficult to measure directly. You usually need something called a metabolic cart. Where I work, we don't have this. You basically have to put a tight-fitting mask on a patient and measure how much oxygen is being delivered to their body. And that mask has to be a tight seal because you can't have oxygen leaking. It has to precisely measure how much oxygen the patient is taking in and out, or taking in and how much carbon dioxide they're blowing out. We do this in our pulmonary lab, but that's separate from our cath lab. Some places that do a lot of research or are very sophisticated can do both and can measure VO2. But most places cannot measure VO2, so you get an assumed value. So our cath lab here in Kentucky, the cath lab software can measure a VO2, which is an estimate. The problem is that estimate is based on healthy people. People, by definition, getting a right heart cath are sick. So this is prone to error. So it is now strongly recommended that if you cannot measure VO2 precisely, you should not report a Fick cardiac output because you're not really getting a Fick. Fick implies direct measurement of VO2 using the formula. And if you can't measure it, if you're using assumed value, it is prone to significant error. So if you can't use Fick, what do we use? And that's called thermodilution. So this is where you inject. So as I mentioned earlier, the PA catheter has multiple ports. There is a proximal port where if you inject saline, it will be ejected from the catheter, not at the tip, but at a proximal location. I'm not sure direct, I think it's like 20 to 30 centimeters proximal to the tip, but don't quote me on that. I actually don't know the exact location. So in a patient, that will be ejected into the right atrium. So if you inject 10, so what happens is you have the tip of a Swan-Ganz catheter, the tip has a thermistor, which can measure changes in temperature. So you inject cold saline into the right atrium, and then the time it takes for that blood to get into the tip, and then the time it takes for the temperature to return to normal will reflect the cardiac output, and that's calculated by the computer. So when I see a patient in the cath lab, you will see the temperature change. When you inject, you'll see the temperature drop because the saline is cold, and this is body temperature. The temperature of the tip will drop, and then it will go back to normal. In a normal cardiac output, this will happen quickly. The temperature drop is quick, and the return is quick. In a patient with low cardiac output, the drop is gradual because it took longer for that cold saline to get there. And then the return is gradual because then it's taking longer for that saline to wash away. So you can get the computer then will measure a cardiac output. And what we do is we try to measure several readings to get reproducibility. Because again, there can be variability as well. I'm not going to spend a lot of time talking about the error in this, but there can be error if the patient starts talking at the time, if they have PVCs, if you didn't measure 10. So this is predicated on the same volume of saline being injected, 10 cc's usually. If you deliver 9 cc's and the next time you do 11 cc's, that introduces error because the computer is using 10 cc's as a guide. You can have error. So what we try to do is we do several readings and we try to get reproducibility. So this is very important, right? Because I want to know if a patient is in shock or if I have an outpatient, is the cardiac output normal or is it low? And this has very important implications to how we manage patients. If your patient is in shock in the ICU and they're on pressors and their cardiac output is low, you may want to call your surgeon and say, we need to escalate therapy. We need to put this patient on ECMO, or we need to consider mechanical circulatory support, or we may need to tell the family that this patient's not doing well. They're not a candidate for escalation because of age, comorbidities, where we have to consider palliative options. When I see patients as an outpatient, I do this procedure. I saw a patient in clinic a couple of weeks ago. I was worried about her. She wasn't feeling well. She came in yesterday for a right heart cath. My partner did it, and she called me saying, hey, the numbers look great. The cardiac output is normal. And then I told the patient, this is very reassuring. Your heart failure is not end stage. You do not need to be worked up for a transplant at this point. So she was very reassured. And so even if you can't measure, you have a patient in the ICU, and they just said the thick formula may not be accurate. But if the other variables stay the same, if hemoglobin stays the same, oxygen consumption stays the same, because the patient is not, having a fever, trends in the mixed venous saturation can reflect changes in cardiac output. So if you had a mixed venous yesterday of 60%, and today, the patient doesn't look as good, their creatinine got worse, their kidney function is getting worse, they don't look good, and now their mixed venous is 40%, that change is important. I don't need a calculator to tell me that patient is probably getting worse and their cardiac output is getting worse. So I just showed you how we get all the variables: right atrium, pulmonary artery, wedge pressure, cardiac output, cardiac index. We now can use those pressures, including other blood pressure, like mean arterial pressure, to calculate several variables. And the paper that one of the goals I had for our paper was to show these formulas in a very easy to read format, because even when I was a trainee, I would forget how to calculate PVR or how to calculate SVR. And so I wanted to make sure that we had very easy to read formulas. And then in our paper, we kind of said, what's the significance of these variables? And so I'm not going to go through these one by one, but we highlight some of the variables that we obtain and why they're important when we assess patients with cardiovascular disease. And so based on the PA pressure and then the wedge pressure, we can categorize pulmonary hypertension. So as I said earlier, the definition of pulmonary hypertension is a mean PA pressure greater than 20. And so then based on the wedge pressure and the calculation of the PVR, we can place patients into one of these three groups. Their pulmonary hypertension is precapillary versus post-capillary, which is also what we call pulmonary hypertension due to left heart disease. And then you have a mixed picture. Again, it's out of the scope of this lecture to talk about each one of these, but just know that this is how, actually I have a slide, sorry. The take-home point is that I would never diagnose a patient with pulmonary hypertension based on an echo solely. Echoes are wrong all the time. There's lots of error. If you are giving a patient a diagnosis of pulmonary hypertension, I would make sure that it is accurate, and I would say that requires a right heart catheterization. You definitely get clues. I mean, there's many patients, I look at their echo and I say, yes, this patient almost for sure has pulmonary hypertension, but you cannot confirm the diagnosis, and you certainly cannot tell the severity without a right heart catheterization. When we see patients that we're considering for LVAD or transplant, the hemodynamics are very important. If we cannot safely do a heart transplant on a patient if their pulmonary vascular resistance is high. The reason being is that the donor heart, which is a normal heart, will not be able to handle the elevated PA pressures in the lungs, and that donor heart may fail. So every patient that we assess for transplant, the right heart cath is not just useful to tell the severity of their heart failure. We obviously need this to show that, yes, you are sick enough to need a transplant, but it's also there to make sure that they're a candidate for transplant based on their PVR. Conversely, PVR is not so much an issue if we're looking at somebody for a left ventricular assist device, but the key thing with a left ventricular assist device, LVAD, is that it supports the left ventricle. Will the right ventricle be good enough? And again, echo can give us a guide, but no program solely looks at an echo. So I could look at an echo of a patient and say, yes, that right ventricle looks good enough for that patient to get an LVAD, but we need to assess the right ventricle by hemodynamics. And that's based on two of the big factors are the ratio of the right atrial pressure to the wedge pressure, and then something called PAPI, which the formula for that was on that slide a couple of slides ago. And that has a lot of prognostic significance in our field, in the heart failure field. So we often, when I'm seeing a patient in the cath lab getting a right heart cath for consideration of an LVAD, I make sure I report the PAPI because that will be one of the key variables that we look at. As I said earlier, right heart cath is utilized in shock to get serial hemodynamics. Number one is it's very important for us to tell what type of shock is this. Is this left-sided shock? Is it right ventricular shock? Is it biventricular shock? Because all those have different implications as to how we manage the patient and their candidacy for mechanical circulatory support. Again, if somebody has right ventricular shock, options like an LVAD are not there. There are now right-sided devices we could utilize. So again, you cannot use an echo to tell this. You need invasive hemodynamics. And then when you have hemodynamics, what are our goals, right? So when we're rounding in the ICU, a doctor may say, we want a diuresis patient till we get a wedge of 15, right? So you may say, well, what dose of Lasix do I give? It's like, well, you start with a dose and see how they respond. If the patient had 1 liter of urine, but their wedge is still 25, you need to give them more. If you give them a dose of Lasix and they've peed 3 liters and now they're a little bit hypotensive and their wedge is 12, you need to back off. So we use the hemodynamics to guide therapy. And then I'm not going to go through this whole slide, but we often use hemodynamics, right heart cath, to measure portal pressures. The Swan catheter can actually go into the hepatic vein, and you could wedge the catheter in the hepatic vein to get a measurement of the portal venous pressure. So I don't do this a lot. Actually, I've only done it once. One of my partners does more of them, and one of our interventionalists will actually do a liver biopsy at the same time. So he'll get portal pressures to look for portal hypertension, and at the same time, he'll do a liver biopsy. So again, this is something we mentioned in the paper, which I was quite happy that we talked about it, because in the heart failure literature and the cardiology literature, using a catheter to measure portal pressures is not widely discussed. It's discussed in the liver, the hepatology literature, but it's not really been discussed in our field. So we show this, we explain it and show this diagram in our paper. So I strongly suggest you look into that, because it's a rather unique feature of what we did. So some other indications for right heart cath, when we have patients with an LVAD, the only thing you can set on an LVAD is the speed. So what speed should we put on the patient? Historically, we use echoes to guide the speed, but there's some idea that we should use hemodynamics to guide the speed. So while the patient's in the cath lab with a catheter in place, you can adjust the speed and see how the wedge pressure and pulmonary artery pressures change. And then I didn't spend any time talking about it today, but we often now in some centers will have a catheter, while the patient's in the cath lab with the pulmonary artery catheter in, you can have bike pedals at the end of the cath lab table, and you can have the patient exercise, and you can look at their response to exercise. So again, one of the limitations of right heart caths are that we're getting these pressures at rest. How do hemodynamics respond to exercise is become now a very hot topic in our field. Again, not done in a lot of centers, but it's becoming more widely used, is that you can actually, while the patient's in the cath lab, have them exercise and see how they respond. So the final thing I want to mention is you spend all this time getting the data. All this data is useless unless your report is accurate, right? Because you yourself a month later may say, oh, I don't remember this patient. You're like, you did the procedure, and you're like, oh, okay. So you want to make sure the report says what you found, and you should do it, obviously, like any procedure, right after you did it, because you have no idea once you become an attending and you get phone calls, and then you later forget to mention something that was very important. So try to do it as soon as you're done, and you want to make sure you perform the relevant calculations. If the data is accurate, somebody else can do the calculations, but you should be very thorough. And if the patient, the doctor will want to see what the PAPI was, or calculate it and put it in your report. You want to report any confounding factors. Sometimes you could not get great numbers. because of PVCs. The patient was not, having back pain. They were not comfortable. That made their blood pressure go up. And you're like, I'm not sure if these are reflective of a resting state. And so that should be mentioned in the report. Because maybe you should sedate the patient. Maybe you should say, maybe we should bring the patient back, put them under some sedation if we really need to get good numbers. I always like to say what drugs the patient was on. You could get hemodynamics on a patient and they look great. You'll say, why was this patient in the hospital? These numbers are great. But the numbers were great because the patient was on several drips. So that's why the numbers look good. So I think you need to say that in the report. Hemodynamics looked better than a week ago because the patient now got X, Y, and Z done to them. So I definitely think that's important to measure the report. And in our cath lab, like most cath labs, they always will record the hemodynamic, the tracings. So even later, if I go into the system, if I'm like, that number didn't make sense, how do the tracings look? In our electronic system, I can get a copy of the tracings. And it's saved. And if I can't get them because of some glitch, I can go to the cath lab and get them. So you can always review the tracings at any point in time. These are just some of the other articles. Again, we wrote a paper that was published in JACC Heart Failure, but these are all, there's many papers about hemodynamics. These are some other papers that are very helpful that I just wanted to note. Again, my slides are not proprietary. I'm happy to share these with anybody. But here's my contact information. You can find me on Twitter. Here's my email address. So hopefully this was helpful. I know this may have been a whirlwind. Maybe some things may not have been exactly clear, but I just wanted to provide a basis for what we do to hopefully foster any future reading and future discussion. But sorry if I went a little bit longer than I thought I was going to, but definitely happy for your attendance and happy for being here, and appreciate your time and taking the time out of your evenings to hear my talk. Thank you.
Thank you, Dr. Naveen Rajgopalan. Excellent talk. Even though I'm hearing for the second time, it is sounding as if it's the first time I'm hearing once again. So it is so informative. Only one question from my side is, usually we give the very much importance to the dichrotic notch in the aortic end side, aortic vessel. But you are talking about the dichrotic notch in the pulmonary artery. So can you highlight that a little bit more, where we have to give the significance of it?
Yeah, so let me just, I can go back to that picture. So here, here's a picture. Can you see my cursor? Does my cursor show up or no? So this yellow arrow points at the dichrotic notch. So that's where the pulmonary valve closes. So there's a hitch. And so in terms of where this occurs, I'm not aware of any significance to say where the dichrotic notch occurs. Its significance is to show that you're in the right position, but also to show that you're not dampened, right? So this is an accurate waveform. But this is a textbook picture. Like in the real world, you may get a tracing, the patient may be tachycardic, and there may be some whip in the catheter is moving back and forth. It may not be this clean, but what you want to avoid is seeing something like this. This looks like a sine wave, right? This is not normal. This when I say not normal, this is not an accurate waveform. You need to flush the catheter because it should never look like this. So really the dichrotic notch is more important to see it, to know you're in the right location. But, I do these in the cath lab. So I know I'm in the right location because I can hit the fluoro and I can see that the catheter is in the pulmonary artery. So it's more so to show that your waveform is an accurate waveform. But there may be times when you don't see the dichrotic notch just because of how the waveform looks. And I'm not here to tell you that it's that important, that you have to spend time noting it, but it's something, for people that are new trainees, when I have new fellows in the cath lab, I'm like, look, that's a dichrotic notch, because they may only think you hear these things in textbooks, but you can see this. You're right. In a left heart cath, when you have a catheter in the aorta, you also see a dichrotic notch with the aortic valve. And then in that case, it's because of the closure of the aortic valve.
No, my question is there any significance to know in different diseases, the dichrotic notch of the...
Oh, great. Yeah. I'll be honest. I'm not aware of that for the pulmonary artery. Now I think there are some different signs, but I didn't look at that for this. So, but let me do some reading of that. I have your email address. Let me see what I can find.
Sure. Thank you. I'll request now Dr. Sorry.
Ma'am, there are some questions in the question answer box.
Yep.
Dr. Naveen, one of the question is, how would be the tracing in pulmonary veno-occlusive disease?
Ooh, that's a great question. I must admit I don't have the answer for that. I don't want to tell you anything that's wrong because decades ago, or not that long, 10 years ago or so, over 15 years ago, I was working in the pulmonary hypertension field, but I gave that up. So I don't see patients with PVOD, and we didn't highlight that in this review. So I'll have to look that up. I don't know what the characteristic tracing is with PVOD. I do, yeah, I don't want to even hazard a guess and tell you something that's wrong.
One of the other questions is, if the PVR is high, how long do you give medical therapy and when do you decide on a VAD?
Yeah, that's a great question. I kind of didn't talk about that. So if you have a high PVR, you can do a couple things. If you can actually give them drugs in the cath lab to show reversibility. So sometimes we'll give the patient either nitric oxide or nitroprusside. There's like 4 or 5 different drugs that are validated in the literature. And if you see reversibility, you could consider that patient for transplant. You could also say, I'm going to leave the catheter in the neck, put the patient in the ICU, and optimize their therapy with diuretics, with maybe milrinone, and try to see if I can improve the PVR. You also may say, maybe it's a patient that's never been on therapy, never been on anything. So you put the patient on a drug called milrinone, which improves cardiac output. It's also a pulmonary vasodilator. In the United States, you can actually do continuous milrinone infusion and then send the patient home. So sometimes what we've done is we've put the patients on milrinone and then bring the patient back in like a month or 2 months and see if the PVR is better. So it depends on how sick the patient is. Maybe the patient's so sick, we don't have a month or 2 to wait, and we have to determine within like 2 or 3 days, can this patient be listed for transplant? Now, the other thing is sometimes the PVR is so high, like over, the PVR is the formula, if you use it, you get it in something called Wood units. So less than 2 Wood units is normal, over 3 is abnormal. But if you see a patient with a PVR over 6 Wood units, so that's severe, you may say, I'm not going to even think about a transplant. This patient just needs a VAD. And then hopefully months after their VAD, their PVR gets better. I'm being a little vague because it depends upon your institution and how sick the patient is. So I may tell you what we're doing here at UK, at Kentucky, but what we did 5 years ago may have been different when we had other doctors involved. So it's a great question, which doesn't have a simple answer because it depends upon other factors as well. But the one thing is, if you cannot get the PVR down, like usually less than like 4 Wood units, many transplant programs would consider it a risk. But a big program, like a big center, may say, we can still get the patient through it. So like anything in life, it's what risk are you willing to take? You may say, I'm going to take a chance. The PVR is high, but this patient is young. We really want to transplant them. Let's give them a heart and the heart will recover. And you may be right. So there are patients with high PVR that still get a heart transplant and still do well. All this, there's no rules, but you have to recognize it is a risk factor for a adverse outcome after a transplant, but it's not a guarantee. There's nothing that will say, well, this patient can never get a transplant.
With regard to the same question, one of our doctors have asked, what drugs would you like to choose when a patient has high PVR, with the aim that we can reduce the PVR and make the patient suitable?
Yeah, so for long-term use, the biggest one we use is milrinone. So the inotropes in the United States that we use for inotropic support are dobutamine and milrinone. Milrinone is probably more of a pulmonary vasodilator. So most programs use milrinone anyway. So I use it instead of dobutamine anyway. But if your patient has elevated PVR, Sildenafil is an oral drug. There's no data with we think it's safe, but there's no data. The data with heart failure is murky with sildenafil. Long term, you're not supposed to use drugs like Flolan or like Bosentan. But the other option is to do not a drug, but to do mechanical support. So we sometimes will put a balloon pump in a patient or a Impella device, which is a temporary LVAD, and that unloads the left ventricle, and then the PA pressures come down and the PVR can drop. And that we do in the ICU over a period of several days. But in terms of, nitric oxide is okay, but it's inhaled, so it's hard to keep somebody on an inhaled. You can't send somebody home on it. Nitric oxide is also very expensive, so to leave somebody on it in the ICU while they're waiting for a transplant has a lot of logistical challenges. So usually the medicine, if we're going to use, is sildenafil and milrinone as drugs, but and then diuretics, and then considering mechanical support like a balloon pump or an Impella.
Would sildenafil or bosentan, would it not be counterproductive if we are using in a patient with severe LV dysfunction, like a DCM or a post-myocarditis?
Yeah, so Bosentan there is data that shows Bosentan caused harm in left-sided heart failure. So yeah, so I would never use Bosentan. Sildenafil can cause harm. It's a subject that is debated heavily in the heart failure field, but it's not. We do still use it in some patients, but you have to be because we don't think it causes increased mortality. But the data is it's single center, it's retrospective. There was going to be a prospective study, I know, because I was going to be one of the centers for it, but then they couldn't get funding. So there's never been a prospective trial of sildenafil in left-sided heart failure. But so it's not wrong not to use it. Some people have very different opinions of it. I think if you're going to use it, I would use it in the hospital and monitor the patient closely, because if they do get worse, if they get more hypoxic, then you can just stop it. But there is data. People have used it in left-sided heart failure, but it's small studies. But it could be overused. I would not just use it. The only time I use it is to get people to transplant, right? So then it's temporary, right? I'm giving a patient a drug temporarily to try to get them to transplant. I would never send somebody home on it to use long term.
So just one last question. Would any lung disease change the capillary wedge pressure? Like, say, some interstitial lung disease?
Yeah. Yeah, so that if you read some of these articles about wedge pressure, that's one of the caveats, that if you have severe lung disease and depending on the zone, that can interfere. So at the end of the day, if you're worried about lung disease, if you just don't know, there's no way to prove that, right? So lung disease can interfere, but you don't know if it is interfering. So if you as a clinician have really need to know what the wedge pressure or the LVEDP is, and you have concerns about the inaccuracy of the wedge because of lung disease, you probably have to do a left heart cath and put a catheter in the left ventricle, because that's the only way to tell. But you're right, there is some thought that severe lung disease can interfere, but there's no good way to prove that. And that is not, there's no, but there's no rule behind that. And so you would have to get a catheter in the left ventricle to prove or disprove that.
I think one last question, I think we just discussed how to diagnose reversibility during RHC, and does VAD help if it is irreversible?
Yep. So if you have irreversible, so there's many different agents at UK where I work. So University of Kentucky, UK, not United Kingdom. We use either nitric oxide inhaled, or we'll use nitroprusside IV. Some places use other drugs like prostacyclin temporarily. But yes, if you have a patient with irreversible pulmonary hypertension, and you VAD them, it is very common that if you 3 months later after their VAD, they're doing great, they feel great, you repeat the right heart cath, their PA pressures may be completely normal. So not just better, they are completely normal. And that's always very gratifying to see. I actually have a case report that we published, a patient with congenital heart disease that had a PVR 8 or 9 Wood units, something crazy. And we've added him. And then 3 months later, it was normal like you and me. The PVR was completely normal. So that, and we got him to transplant. He's now 10 years out and he's still alive from his transplant. So forget what journal we published that in over 10 years ago. But yes, that is definitely an option for irreversible pulmonary hypertension.
I think most of the questions are answered. So one is on a operability cath. In AST or PDA, when the PA mean pressure is very high, but the wedge pressure is very low. So the patient is operable or not?
Yeah, so
yeah.
well, these are great questions. Yeah, so I should have mentioned this. Some of the calculations, at least in terms of the cardiac output and things, they're not applicable if you have congenital heart disease with a shunt. So when you have a shunt, one of the most important things to calculate is the shunt, the severity of the shunt with what's called a QP/QS ratio. I did not talk about that intentionally because that is definitely out of my expertise. That is expertise of the congenital team. And so, yes, I mean, the bottom line is that if you have severe pulmonary hypertension, that is a risk for a bad outcome in terms of failing the RV. But if you can't fix the shunt, that patient will not survive very long. And so, yes, you want to get to the shunt before it becomes pulmonary hypertension is reversible. But in terms of what you're asking, at what point does that patient not a candidate and needs to be considered for a lung transplant? That's a very difficult question, and that's a multidisciplinary discussion between a congenital surgeon, a congenital cardiologist, and the pulmonary hypertension specialist. So, but those are very complicated cases.
Ma'am, would you like to make any concluding remarks? It was a very illustrative session. I think right heart catheterization is not commonly practiced in most of our setups. We got a better understanding, and maybe we will practice more in our ICU and help us in management of patients in a slightly better way, because always managing chronic heart failure is a big challenge. Ma'am?
Yeah, so I thank you. No, I'm very appreciative of the time. Yes, even in the United States, right heart catheterization outside of the ICU is rarely done outside of transplant and VAD centers. So in the community hospitals, even with cardiologists, it is not common that this procedure is done. So it is very underutilized. And so when patients are sent to me, a doctor is like, I think this patient needs a transplant, one of the first things I do is oftentimes get a right heart cath because they've never had one before. So a patient for 6 months was getting worse and getting worse and getting worse, and they never had this test. And so ultimately, you don't want a doctor to do a test if he can't interpret the results. So I always tell doctors, if you think your patient needs a heart cath, a right heart cath, and you don't feel comfortable doing it, refer them to me and we'll do them. We do them all the time. My partner was in the cath lab yesterday and did 4 cases. The previous day, she did 6 cases. I'm in the cath lab next Wednesday and I'll have 4 cases to do. So we do them all the time, but it is very underutilized, and you want to make sure that you refer patients before they get end organ damage, irreversible kidney failure or irreversible pulmonary hypertension.
No, yeah, last question I want to ask you. Nowadays, the treatment of the choice in a resistant heart failure, they're creating the ASD and putting the stunt-like thing to prevent the backflow from the right atrium to the left atrium. Do you think that is there any indication to do the right heart cath management in this type of the patients?
Are you talking about the shunt?
We create a shunt,
yes,
ASD, and put
yes, that is being studied. Yeah. So right now the data on that, they've published some data. It hasn't, at least in the trials I've seen, hasn't worked out. No, I agree. I think certainly before considering that, I think the creation of an intra-atrial shunt, the benefit that they've shown so far is with hemodynamics. So they've shown that it drops the wedge pressure. So you're right. I think it has utility to show improvement. The question is, does it cause clinical improvement, right? No patient cares that their wedge pressure got better. They care that they feel better and they stay out of the hospital. And so that remains to be seen with these technologies. But yes, the technology so far suggests that it does work to improve wedge pressure.
Yeah, thank you. Really, it's a very excellent talk and a very good discussion. And even though we are beyond the time of 10 minutes, and really we are happy that you could spare time.
Oh,
and
thank you.
Dr. Hema and Dr. Rupali for organizing this along with eminent people. Thank you all. Thank you very much, sir. Thank you once again.
Yeah, thanks. All right.
Bye. Yeah.
Bye.
Thank you, ma'am. Thank you, sir.
Thank you so much.